All right, this is going to be a quick review over pharmacology. We're going to go into some medications. I'm going to get a little bit more in depth, and I'll share with you any information I have regarding anything that I've seen related to these medications and the big three. And remember, the big three is going to be your standardized testings, your NCLEX, your exit HESI, or things that I see commonly in a hospital with that medication and what it's used for. So you're about to get a lot of information because I don't quite know, obviously, what your examination looks like because they're going to be varying. But they're all basically the same types of questions. So let's just jump into talking about them, and let's crunch all of the information we can and throw it into our brains and keep it for later and be successful in our next exam. So grab a Coke, grab a water, grab some popcorn and some no-dos, because we all know that my wonderful little monotone voice is quite lullifying, and also on top of it, it's nice and deep because I am getting over a small cold. So cool. It's going to sound like I'm going through puberty for, 15 slides. So here we go. 1, 2, 3, go. Ready, set, go. And let's do it. All right. Here we go. So let's hope we don't have any kids screaming. Oh. Nice. I think we're done. Okay, cool. Nope, we're not done. Okay, I think we're done. All right, cool. So oxybutynin. Oxybutynin is known as ditropan. It's a medication that treats loss of bladder control, a frequent need to pee, overactive bladders. You can take the medication by mouth with a glass of water. Oxybutynin, it treats symptoms of an overactive bladder. So loss of bladder control, frequent need to urinate. It works by relaxing the muscles in the bladder. It's called an antispasmodic. Spasms mean contractions, right? Uncomfortable contractions of the bladder can cause you to have leaks. This happens a lot in women who have had multiple babies. So usually when they have, 3, 4, and 5 babies, this is a problem. Although there are other things that you can do, such as pelvic floor exercises that they usually try to work with you individually to see if that will help the bladder leakage problem. And 9 times out of 10 it does. So these are usually for the people that are not successful with pelvic floor exercises. And don't want to do anything like a bladder mesh, which is a pretty significant procedure that causes a lot of complications in itself. So what we do is we give them ditropan to see if that fixes the problem in between all of it. So it relaxes the muscles in the bladder, and the medication can be used for other purposes too, but traditionally this is an antispasmodic used specifically for those bladder issues and issues related to problems with having too many frequent spasms and having that leakage. Now, the other issues that you could have related to this that we would give ditropan for it would be like multiple sclerosis would be a good example, right? Because we have a neurological issue that is causing the deficiency versus it being a renal issue specifically. Does that make sense? This is more of a neurological problem because it's the signal in the brain that sends the signal to the bladder to do its job, and that there's a disconnect in that signal because of, multiple babies kind of wrecking that signal, if you will, without putting it too bluntly. So there's that. All right. So there are conditions that you cannot have if you take this medication. So autonomic neuropathy is one of them. Autonomic means it happens without me thinking about it. So within the subconscious, within the cognitive processing of the brain, which is why I was telling you this is a neurological problem a lot of times related to autonomic neuropathy. Dementia is another one. Again, neurological disorder. Any difficulty passing urine in general. Glaucoma, you can't have glaucoma and take this medication. Any intestinal obstructions, any kidney disease, any liver disease, any myasthenia gravis. That's my big scary one. Everyone knows that. Parkinson's disease is another one you can't take the medication with. Unless you have obviously if you have an allergic reaction to the medication, that's a no-no. If you're pregnant or you're trying to get pregnant, or if you're breastfeeding, because these will pass along to kiddos, and kids under the age of 5 should not take this medication unless it is understood as a necessity that outweighs that outweighs benefits versus risks and comes out more benefits versus the risks involved in taking the medication. Again, you take it with a glass of water. You can take it with or without food. You take your medication at regular intervals. So if you miss a dose, then you would just simply take it as soon as you remember. This isn't one of those deals where you would have to wait until the next time around to do that. Let's see if I'm missing anything that I can think of. Oh, speaking of doses, if you do forget your dose, take it as soon as you can. Let me put in the caveat. If it's almost time for your next dose, take only your next dose. Don't take the double dose, because this is one of those medications that if you get too much of it, it can cause you some serious issues. All right. So, interactions with medications, again, atropine, antihistamines, certain medications for bladder problems, Parkinson's disease medications, like, let's see, benztropine is a good one that they use. All of these medications, by the way, all of these medications create an increase in your propensity or your chance of having some issues related to cardiac and cardiac episodes, tachycardia, things of that nature, because antihistamines, atropine, both of those medications right there are known for raising your heart rate. Right. So like for someone like myself who has, autism spectrum disorder, and a lot of people also have ADHD if you have autism spectrum disorder. So you take ADHD medications, which is a medication that elevates your heart rate. Right. So if you're taking any of these medications, you don't want to take ditrophan on top of it, because what's it going to do? Well, it's going to send you into a potential for supraventricular tachycardia. As well as it weighs on your heart quite heavily. So you got to be really carefully, or you got to be very careful for those things. Also, you can't take erythromycin with this medication. Ipratropium we talked about, it's ipratropium. And then I think that's it. Maybe any mycins, erythromycin, clarithromycin, claritromycin. I think that's how you pronounce that. Those are the two mycins that you got to stay away from as well with this medication. Also, medications that are for fungal infections. So anything that ends in azole, azole is the end of it. I'm going to do a pharmacology lecture, I think, on suffixes, because the suffixes like the azoles or the IDIPINE medications, they tell you what kind of medication it is. Like every medication, if the last couple of letters match, then that is a classification of medication. And there's actually a song that you can YouTube, and I can't remember it, but I learned it in nursing school. See if you can do it. Do pharmacology medication song. And there's a song about the IPENs and the alols, the OLLL, right, which are the beta blockers, things of that nature. So I would encourage you to also look at that to help you remember these while you're going on. But just so that you know, erythromycin and claritomycin, something of that nature, however I spelled it. Those are the two medications you cannot take with this medication. Again, because it messes up a lot of things. Specifically, it messes with your conductivity and contractility of your heart, which is a big problem. That's all I've got for ditrophan that I can think of. So your question is usually going to be relatable or related to a patient with a bladder problem or a patient who has had a traumatic brain injury. And you would know that this medication would be necessitated for someone who does have bladder leakage, who does have painful spasms, things of that nature. So we can go to the next slide. I think I've ran everything into the ground that I can run into the ground about ditropan. I think I have. If not, I'll go back and redo the slide. But I think we're good. So let's move to the next one. All right, so digoxin is not my best friend. It's the bane of my existence, if I'm honest, because I'm sick and I have to talk about dig, which means I'm going to be doing this for a hot 5 minutes at least. And I'm not looking forward to it because after I get 2 or 3 sentences in, I start to lose my voice. So here we go. Digoxin is used to treat heart failure, usually along with other medications. It's also used to treat certain types of irregular heartbeats. Atrial fibrillation is one of them. Treating heart failure may help maintain your ability to walk and exercise and may improve the strength of your heart. Anytime you see a question that says always, unless it's talking about patient safety, and even then it's sketchy, don't pick it. There is no such thing as always when you're dealing with 7.8 billion people in the world who all have opinions on a medication. So if you see the word all in any instance, unless it says our goal is to attempt to have safety for all patients, that is the only time I've ever seen that exception work. You never pick that answer. So that gives you a better chance of picking the right one. Okay? So medication, why is it easier for me to exercise if I have my AFib contained? Well, think about it. If you go outside and it's hot summer, first dead day of summer, and I have not turned on my hose, and you turn on that hose to water your plants, what is it going to do? It's going to spew, go boom, boom, followed by a pause of nothing but hot air, followed by a flash of hot steamy air, right? That's AFib. It goes doom, 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 doom. That's what your heart sounds like instead of doom, 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 right? So what does that mean to my brain? Well, what that means to my brain is I'm not getting a free-forming, free-flowing source of oxygen all the time. So why is that going to be problematic for me walking to point A to point B? Well, if I walk 150 feet to go to the bathroom and I'm not oxygenated, my brain shuts down. Oh no! What does that mean? Well, with any luck, you're not going to die. But what it means is it temporarily shuts down your ability to do the things that you need to do. So there might be a mental disconnect between go here and go to the bathroom. Or you might get halfway and get so oxygen depleted from the AFib that you get dizzy and stop. Or perhaps you can't make it because you're out of breath. So you don't make it, right? These are the problems that we have. So this is why we take this medication. The medication type is called glycosides. Now, what it does is it works by affecting certain minerals inside of the heart cells, specifically the sodium and potassium chain, but I'm not going to get into that and freak you guys out. If you want to watch the sodium potassium pump business, you can. You can just YouTube sodium potassium pump. That'll get you where you need to go in 4 minutes or less. Also, the sodium and potassium pump that works inside of the heart cells. It reduces the strain on the heart and helps it to maintain normal, steady, and a strong heartbeat, which is going to give you a better, more consistent blood pressure, which is not going to make you hypotensive. So here's the thing with medications regarding digoxin. You can take it with food or without food. That's no big deal. Use it as directed by your doctor. You have to make sure that you have an apical pulse that is above 60. If it's 59, don't give the medication. If it's 61, I hate those days. If it's 60, 61, if I were you and they were laying in bed and they were ambulatory, I'd make them walk around a little bit if I were honest. That's just me personally. But it needs to be over 60. Apical pulse has to be checked for 1 full minute. No exceptions. Okay, that's that medication. That's that one caveat. There are many other caveats. I told you guys I was going to lose my voice. All right. There might be some serious allergic reactions to this. Related to allergic reactions with digoxin, rash, itching, swelling, especially of the face and the tongue and the throat, severe dizziness, trouble breathing. Those all sounds like super, super big deals to me, right? So these are the ones that I would be watching out for. Before using the medication, you also have to tell your doctor or your pharmacist about any type of kidney problems or thyroid problems. underactive or overactive, okay? It is going to cause you, this medication is going to cause you to get dizzy because it is meant to drop your overall cardiac conductivity and contractility to give you a better, more steady existence of a blood pressure. So what it will do is it is going to drop that blood pressure. And part of dropping that blood pressure is you might get a little bit dizzy, okay? Do not, I repeat, Nikola Tesla loves things in threes. Do not consume alcohol or marijuana. It's going to make you more dizzy if you take this medication. I had a patient that was a avid marijuana user and started DIG and thought he was going crazy and didn't know why. And I'm like, dude, lay off the cannabis. Duh, that's why. That's the whole problem. So they did. And guess what? Everything was fine. No big deal. Also, you have to make sure that you don't have out of whack potassium, magnesium, or calcium. You also don't want to have water pills on deck, because if you do have water pills, you're going to have a lower potassium. We'll talk about diuretics, especially if they're Lupa-Henle diuretics like Lasix. I'm sure we'll get into that later on. So watch out for things like water pills. Also, make sure that you don't do anything like take DIG and then go get an like a cardioversion. That would be a bad day. Unless your doctor says it's okay. I'm trying to think of anything specific to digoxin as far as just the drug itself that you need to be aware of. Not necessarily what we need to know related to potential questions. So this is a cardiac glycoside. Let me make this perfectly clear. They are a classification of medication, specifically digoxin, that has a positive inotropic effect, that has a negative dromotropic effect, and that has a negative chronotropic effect. I don't know if you need to know those bits and bobs just for the beginning levels of a pharmacology class. For an extended pharmacological assessment on a master's or doctoral level, I needed to know those things. I don't remember if I needed to know those things as just a flat out nurse, if I'm honest. So you might want to check with that. Again, no DIG if you're on a medication that could cause problems with potassium, such as Lasix, also known as furosemide, okay? They have to have special consideration for that, so it's not going to be something that we would normally do feeling comfortable, all right? We also need to look at issues like, again, low potassium levels are always going to be a problem related to digoxin. Usually they tell you that a patient has been found who just started digoxin. Which one of these should you be most concerned with? And then you just look for the low potassium. So anything under 3. Usually it's 2.9, 2.8, 2.7, things of that nature. And then you'll know that that's furosemide, the answer that you're looking for. Therapeutic range is 0.5 to 2 nanograms per milliliter. So 0.5 to 2 nanograms per milliliter is going to be our normal range. They being the patients, need to be aware that they need to measure their pulse every time they take it. And it's important to talk to their doctor immediately about any vision changes during taking this medication. That is going to be a potential warning for extreme hypotension and also being orthostatic hypotensive. Okay. Let's talk about toxicities. Toxicities are going to be anorexia, nausea, and vomiting. Whenever your body doesn't like a medication, it tries to kick it out of your body. It does it through nausea and vomiting. Those are pretty normal. However, anorexia is more related to the leptin and ghrelin hormone dump that's going on, and that medication specifically removes the ghrelin from your body, which says, "Hey, I'm not hungry. If I'm ghrelin, my belly's growling, which means I'm hungry." So it kicks that out and says you're not hungry at all. So you just don't eat. That's another common one that I've seen. I think that's about it. I think that's about it. Just make sure that you're paying attention to the medications that will cause issues related to potassium. That's the bigger deal with digoxin. And I think that's it. Read your book and see if you see anything else in there that I might be missing that might be important, or check your chapter reviews at the back of your book, or at the back of the chapter, or go ahead and do your activation code login. And when you do your activation code for your Elsevier book, it will give you a chapter assessment review, and all of those questions will be on there related to the things that you need to know specific to digoxin, because digoxin is a big hot spot. All right, let's go to the next slide. So hydrochlorothiazide. Hydrochlorothiazide is used to treat edema, sure. Help reduce the amount of water in the body, yes. It's also used for a couple of other things. We use it, believe it or not, to help people with acne vulgaris. That's an option. Is it going to be on your exam? No. Is it an incidental you think is going to be important later on? Yeah, for sure. There's a lot of people that have acne, just FYI. However, what's the caveat with this medication? I can tell you, the bigger issue of all of these issues in the entire world over here into the side effects is going to be, let me do my little drawing tool, orthostatic hypotension. That's a big problem. Paresthesia is a fairly big problem. Blurred vision is going to be as an incident of your orthostatic hypotension. That's not hypertension, it's hypo. H-Y-P-O. There we go. Cool. Sorry. One of my wonderful students created this presentation and got a little bit of it wrong, but that's cool. Hypotension, fantastic job. That's done. Because obviously we're lowering the blood pressure as well. And hypokalemia, hyponatremia, hypercalcemia. When we're talking about this medication specifically, first off, I want to talk to you about compliance. You rarely get good compliance on this. Why? Because, well, about half of the people, which is about 43%, have a very, 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 very serious effect. And I was one of those 43% of those people while I was incredibly pregnant, working 18-hour shifts, 16 for the shift and then 2 hours home, because I was a traveler. Being very pregnant and having +3 pitting edema, that sucks doing that 18 days in a row. So I called a cardiology friend of mine, and they ordered me a dose of hydrochlorothiazide to help me with a little bit of relief in the last couple of days before the big push of the baby and bringing her into this world. And let me tell you, I will never do that again. And why? Because I woke up at 2 in the morning, and you guys know me, I'm very, very tough. I don't even have a Tylenol to give birth, and then I'm making the bed in 5 minutes. It is what it is. I woke up, and I was toppled over from a pain that felt like I was being impaled, from the cramping, from the sheer cramping, okay? This is why people are non-compliant with medication, because 43% of the people who complain about cramps, when they say, yeah, I get really bad cramps, they don't define what the cramp means. I don't know why people can't communicate with other people in this world. It's very simple. Just be blatantly honest, even if it might be a little on the aggressive side. So they tell me, oh, I have little cramps. Do you think a doctor's going to be like, oh, it's not that big of a deal? No. I looked at the doctor and was like, dude, you gave me this stuff and I felt like I had been impaled with a lightning bolt. I don't know how else to define it, to the point to where I had to make sure I didn't have a DVT, and I didn't. It was the hydrochlorothiazide that did it. So when you look at a patient and they're non-compliant with your medication and you want to roll your eyes at them, I want you to remember that. What does that feel like to you? When literally one of the toughest gals, or one of the tougher gals, how about that? Like, I'm sorry, I'm one of the last feral children in the generation, right? Like, it was martial law in my heyday. I'm just FYI-ing you guys. So if it's that much pain, why would you insist on telling that patient they need to be compliant with their medication? Write them down as a non-compliant patient and then just write them off. What are you doing to yourself? What are you doing to that person? Why would you do that? Okay? Remember, there's ripples in the pond. You throw a little pebble, it creates a tiny ripple. You throw a freaking boulder, the whole place shakes. Don't affect someone's bloodline like that. Don't affect someone's generational mess. And then throw it into another generation of oppression and of not being able to do the basic things in life, like read, write, feed their family, okay? Don't do that. Give it an extra second and try to understand what it really feels like, so that you can then go, hey, look, doc, here's the deal. it's not going to happen because he's having those crazy cramps and he's going to be non-compliant. We have to do something different, and then he'll listen. So you need to do that. Specific to examinations, this medication is notorious for creating hypercalcemia, hypokalemia, and hyponatremia. Now, what does that mean for your patient? Well, hypokalemia means their potassium levels start dipping down, which starts causing a whole lot of problems. U waves, for example. How do I remember U waves are associated with hypokalemia? Okay, well, cool. I'm going to give you the deep dive of how I did it, and I don't know if you're going to be able to get it, but it helped. So here we go. Hypokalemia and P waves, or U waves. So U waves, I define those as being related to potassium because I think of PU, something smells. All right, I know it sounds stupid, just hang on with me for a second. I'm wafting my nose down, right? Down for lower. All right, cool. Hypokalemia, P as in potassium, U as in the U wave, PU, something smells. That's how I remember hypokalemia and U waves. All right, that may be a question on your NCLEX. That one comes up often enough. So remember that. And hypokalemia is also going to cause a lot of other incidental findings that we don't need to get into at this point. But referencing hypokalemia, this is going to be notorious. The number one, they are always going to ask you about a patient who comes in, who's having cramps, who is complaining of, palpitations, blah, 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 blah. And they will tell you that they have recently started taking a thiazide diuretic. And then they will also ask you about foods to stay away from. So obviously we know to stay away from foods that are rich in calcium and sodium, or not calcium and sodium, but calcium, because we have hypercalcemia. Hyponatremia, what's that going to mean? Well, that means I am also losing sodium. So if I'm losing water and I'm losing sodium on top of it, we have to really, really watch this person for dehydration. That's an obvious. What happens when you get dehydrated? Well, I can tell you from experience, you get orthostasis. You stand up, everything goes black, and you feel like you're about to fade into nothingness, and that's not a good feeling. So these are the questions that come up on this type of medication, everything I just mentioned. So knowing that you can't have things that are high in calcium because it's going to throw your calcium levels potentially to a bad threshold. Also, knowing that you can't have you can't have Lasix on deck with hydrochlorothiazide. That would be terrible, right? Because one is a loop diuretic, one's a thiazide diuretic, and both of those are potassium out the door. So that would be a bad day, right? So those are contraindicated. Big word for, you ain't doing that. Not today. Not ever. And then hyponatremia, low sodium, that's a big problem for a lot of different reasons. We'll get into problems related to low sodium, but basically just know that foods, which ones they can and cannot have, what type of medicine it is it wasting or sparing, and for which of your electrolytes, and yeah, that's pretty much it. Yep, and the incidental U wave situation. All right, let's go to levothyroxine. So really quickly, going back to hydrochlorothiazide, I want you to know that hyperglycemia is also an incidental related to hydrochlorothiazide. So if your patient is a diabetic, you have to remember this medication will throw you into a state of hyperglycemia. Why? Well, there's a whole bunch of things as far as pathophysiology about the beta isolate cells, the B cells, related to the pancreas and the potassium channel and its predisposition to remain open, and then that causes a flux with your insulin resistance, yada, 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 right? So just know that nerd stuff has been done on my end and information has been set, so this is why we do it this way. Now, moving on to levothyroxine. Levothyroxine is for hypothyroidism, all right? So what happens when a person has hypothyroidism? Well, I want you to think in terms of energy, frequency, and vibration, okay? This person does not have enough of what they need for their metabolism to keep up. So what's going to happen? The metabolism is going to have to make choices, and the choices that it's going to make is, all right, cool. Should I keep her heart going, or should I just make her tired? Should I keep her heart going, or should I shunt that blood to her hair because that's important to me, right? The body doesn't care about your hair. So what's going to happen is the body is going to shunt all of that blood supply. It's going to take what it can to keep it alive-ish Take it and get that reserve and shun it to your heart where it needs to focus to keep your body maintained. So people with hypothyroidism have really, really breakable hair. They have weight gain. Why would they have weight gain? Well, if you're too sluggish to get up and go do anything, all you're going to do is sit and eat and watch TV. No? No? Yeah? Okay. So that's why it's that way. All right. Myxedema is a big deal. When we think about myxedema, coma, we think of people who are oddly specific in their presentation. They're very puffy. They're very sad to look at. Their eyes are bulgy. It's very painful. They're bulgy not in the way that they are with like a hyperthyroid storm. They're bulgy with very prominent faces. I'd give it a Google if I were you, because I can't quite define it right now because my brain is set on pharmacology and pathophysiology and not so much disease processes, because I want to keep right in tune with what our test is about and not grace over into MedSurg 2 material. Just give it a look. Hormone replacement is very important because we have to have that hormone replacement. Thyroid cancer, pituitary, TSH suppression, yes, all those things are accurate. Very good. So when a person is low, they are tired, they are weak, they are exhausted, their hair is falling out, they will have a state of hypothyroidism. Now, side effect are too much or too little. Well, let's do energy, frequency, and vibration again, okay? Tachycardia, is that high vibration? Is that low vibration? Do I think, oh God, I'm so tired when I think of tachycardia? No, I'm thinking bum, 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 like I'm talking. So that would be too much, right? Angina, chest pain. It's not angina. Please don't call it angina. We don't work in obstetrics. It's angina. Angina is, again, bum, 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 right? So think of your issues. Okay, insomnia, too much. Think of the issue, think of the problem, and then think about, is it too much or too little based off of the vibration of this medication. It's meant to speed you up. Period, point, paragraph. It's meant to give you a shift in your circadian rhythm and your hormone dump and your hormone rebalance so that you can then re-regulate, so that we can then shunt that blood back to our hair, get that beautiful lustrous hair back, et cetera, et cetera. That's how this works. Questions related to this. I say all of these things because questions related to levothyroxine is usually, did they have too much? And it's going to say patients coming in, recently started a dose of, whatever, had their medication supplied. And in the event, patients in here with palpitations, they're having angina, they're having insomnia and tremors, yada, yada, yada. What is this a result of? And we know for sure it's a levothyroxine overdose. That's usually how that goes, or derivatives of, okay? So that's how I would look at that. When you're studying for these medications, what I used to do in nursing school is I would Google levothyroxine questions nursing. And then it would give me sample questions. So I knew if the material covered, there's only 10 to 12 questions related to that and they're repeating themselves, well, then there you go. That's all you need, really, and then you can just move on. So keep that in mind for next time. And then we'll talk about warfarin next. Okay, with warfarin sodium, we need to talk about something else besides warfarin sodium because we also need to talk about heparin. So warfarin sodium, I'm going to type this in, and it's not going to be pretty because I'm doing it with my little keypad on my laptop. H-E. Ugh, this is going to take forever. Anyways, while I'm writing this, let me tell you about warfarin. Warfarin is also known as Coumadin. And while we are talking about Coumadin, we have to talk about levels. So there's always a Coumadin level. The problem with the Coumadin level is most people forget if it's heparin or if it is warfarin. So heparin. Heparin is different. Heparin is a low molecular weight blood thinner that we give somebody when they're about to have a heart attack, when they're about to have a DVT, if we suspect these things, all right? So how do we know the difference in lab values? So one is in INR. This lets us know a ratio. And one is an APTT. So the levels for these medications are always, and I say always, they're always mixed up. I mixed up these for years. You're going to mess up a question because of these two things. All right, here's how this works. APTT goes with heparin. INR goes with warfarin. How do I know that? You ready for my hack? You guys know I'm always a weirdo. INR is literally in the word warfarin. It's just backwards. Right there. INR. Okay. Heparin. All right, how am I going to do this? All right, see these two T's? Here's how we do this. Two T's right here. If you click them and make them touch each other and say hi, we're going to high five each other. Guess what? You get a H. Oh my God. Heparin. Whoop. See how we did that? Cool. All right, so I need for you to know the difference in the two of those. INR is always for warfarin because warfarin is RAN and INR is out of RAN. So that being said, what are the issues related to warfarin? Well, you're going to have a bleeding risk, duh. And I mean, you're also going to have frequent values and lab values checked. Sometimes it's daily, sometimes it's every other day. They're constantly messing with your dose. You're constantly walking around looking like a purple person. This medication is not ideal. However, if there is not a better medication for them, this is what we give them. All right. So a lot of people do it. It's cheap. Coumadin clinics are easy to do. So it's monotonous and it's annoying, but it's better for some people. Heparin, like I said, it's usually an IV dose. We do a subcutaneous injection as well. It's pretty standard in the hospital that we give those. But when we're doing like an IV drip of heparin, we're going to use an APTT value. And you need to know the difference between APTT and INR because there's always a question about which value do you need related to which medication. It is 100% going to be on your exam, period, point, paragraph. I don't care if people say I'm cheating. It's there. Like, just look online. It's everywhere because it's that vital to not hurt somebody. All right. Again, vitamin K antagonism. What does that mean? Vitamin K antagonizes this medication. It ticks it off. So what do you think that medication is going to do? It's your antidote. All right. Also, you got to stay away from green leafy vegetables. Why? Well, because the more you eat those, the more your medication wears off. So there is an entire list of medications that you can and cannot have. There are questions about bananas and whether you can have those. And the answer is, yeah, you can have bananas as long as it's not a green one, right? And that's not even a joke. Look it up. Give it a Google because I had to, right? Remember, I'm not a computer. So I had to look that one up, and I'm glad I did because I kind of wondered about that. So problems with this: nausea, cramps, yeah, for sure. Hematuria. Why would I have urine and blood mixed together? Well, because it's an increased bleeding risk. I mean, it's a big one. It's a big one, okay? Coumadin is known for notoriously always having levels out of whack and it being a big deal. So those are going to be your questions related to Coumadin, what you can and can't eat, what levels need to be measured, what are the levels, hello, what are the levels, you need to know the levels, look them up, and what are the side effects, and what is the risk, why am I concerned about this person, increased risk of falls maybe, why is that a big deal, subarachnoid hemorrhage maybe, midline shift in the brain maybe, death maybe, I don't know, it's a thing, happens all the time, happened to one of my patients one time. So yeah, that's warfarin. I will think we have to do theophylline next. I don't know. I'll look and see. So let's just go to the next slide. So theophylline, it is a drug derived from mexilxanthine, I think it is. MEXAL. Yeah, I think that's right. Mexilxanthine. It's a purine derivative. That's all you need to know. And it has a smooth muscle relaxant, a bronchodilator effect, also a diuretic, a cardiac and a central nervous system stimulant. Activities are all part of this medication. All right. So when I hear things like dilation, diuretic, cardiac, central nervous system stimulant, I think, okay, things are on the up. Definitely on the up. I get the vibration of wah, right? I could feel myself talking a little bit faster, right? Because I'm pumped up, right? So this is the vibe that I get off of this medication. And I'm correct because what we're doing is we're triggering. Remember, I am a bear and I'm chasing a person and I'm chasing you and you are covered in honey and I am snacking, buddy, and I can run faster and I weigh a lot more and I'm gonna pin you down and I'm biting. Okay. So what are you doing in that moment? You are running as fast as you can. You have increased respirators. Your heart rate's up. Your pupils are dilated. And what else is dilated? Your bronchioles. Those little buddies are popping and locking and you are kicking it because they are trying to get out of there. So this is how we get that bronchodilator effect. Now, what is the caveat of that? Okay, well, what else is happening if the bear's chasing you in the woods? Your heart rate's 5,000, right? That's an exaggeration, obviously, but it's you're in tachycardia or an extension of maybe something even worse, right? You can't think, you can't be rational. If you notice, nurses, good nurses, they don't freak out. The real hardcore ride or dies, they don't freak out because they know if I freak out, I'm irrational and my brain matters more than anything because that memory bank is all that's going to be between me, you, and death. And I am not going to let that happen. Not on my watch. Got it? That's the mentality you need to keep. All right? Because guess what? If that was your baby, if that was your mama, if that was your daddy, what kind of mentality would you expect to get? Because I tell you, friend, whatever you put into this world will give you back. You take that how it resonates, friends. So, digressing. This medication, fun fact, it is naturally present in small amounts of tea and cacao beans. It was initially extracted and synthesized in like 1895-ish and was used as a diuretic specifically. And then like by 1920, 1, 2, 3, God, I feel like it's 2-ish. It came out for clinical treatment for asthma, all right? So you know this is directly affected with this. So what does it fix? It fixes COPD. It fixes issues related to asthma, infant apnea. I think that they were talking about anosmia, but that's neither here nor there. But I think they were messing around with that at one point, if I do recall. So moving on, how do we need to look at this? So I want you to be able to do the following. I want you to be able to describe the mechanism of action. What does it do? I need for you to review what it's used for. So tell me who gets it. I need for you to tell me the side effects of the medication. And then I need for you to let me know why it's important that you talk to your patient about these things. Okay? So let's talk about what we don't want to do. Okay? So administration, it could be intravenous, it could be oral. There are other rando routes that we can get into. It doesn't matter. Contraindications, things that we need to worry about. If you have any hypersensitivities, that's a problem. If you have any cardiovascular disease, why would that be a problem? Oh, I don't know, because your heart rate is already stupid high. So you don't want cardiovascular upset on top of it because we're just going to, I don't know, step on the puma and then bear weight down and break that toe. You don't want to do that. You don't want to scuff a puma. Pumas are great shoes. You don't want to mess those bad boys up, right? Be cautious always. Cystic fibrosis, all right? That clearance can occur with patients with cystic fibrosis, but this is also a bad idea. Well, why? Well, here's what I want you to do. I want you to look up what a cystic fibrosis patient looks like, how they present, then go back to this medication, see what it does to a person, and tell me how that's going to be a problem. Use the same thing that we just used for cardiovascular. Do it when you're not worried about an exam, all right? Hepatic impairment, that's a problem, right? If you got cirrhosis, if you got, I don't know, cholecystitis, right? If you have hepatitis, you could have fatal complications related to that. Again, part of this is we're shunning everything to the chest. At this point, I am telling my body I'm in sympathetic nervous system. I'm shunning everything to the core. When I do this, other pieces lose vascularization. This is how I need for you to think, okay? What else am I missing? Peptic ulcer disease. Because it's on your slide. Okay, cool. Because I'm not even looking at the slide. I'm just thinking out loud and kind of talking at random, right? Because that's what I do. So peptic ulcer disease, yes. Worry about that. Why? Because it exacerbates peptic ulcers. There is a peptide in there and things that it doesn't matter right now. But what it does is it directly affects this and it causes you to have an increase in gastrointestinal upset or reflux. Yeah, so big deal. And then people with seizure disorders, this is also a big problem. because it exacerbates the seizure disorder. We don't need to get into why. Just know that this is why the problems that we have are related to these issues, okay? So I think we've covered everything. So what do we need to talk to people about? We need to let them know that they might have these issues. If they have these issues, they need to let us know, right? We need to teach them on how to give it properly. We need to teach them on monitoring their own heart rate, their own respiratory rate. They need to watch out for side effects like a headache or that irritability or that insomnia, because we need to lower the dose if that's the case. We need to, make sure that they don't require any other therapy, IV therapy, make sure that their electrolytes look fine, yada, 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 know those big things. Now, a weird thing about this, and I don't know if it's going to be on your exam, but there's usually a question related to beta blockers and theophylline. This is a rando fun fact that I just pulled out of my heads up display that I have in my brain, which is cool. Beta blockers, they could potentially help in reversing severe cardiovascular toxicity related to medications caused by theophylline. So if you have a theophylline upset or overdose, beta blockers could potentially help reverse that toxicity and that severe cardiovascular upset caused by that toxicity. So there's that. I remember a question being on that. I don't know if it's NCLEX. I don't know if it's exit or if it's just farm. But I remember seeing it, and I see it very well. So put that in your little bank, and let's go to the next slide. All right. Let's talk this medication, rifampin. I don't have the strength to go over rifampin, but we're going to do it. All right? We're going to do it. So it's an anti-tubercular, and I get exhausted about this because let's talk about it. You're going to have, no joke, I'm not even playing, you're going to have about 5 to 8 questions related to tuberculosis and rifampin, or related to tuberculosis. So I have to physically go through all of this, and friends, it is midnight, but I'm going to do it, and I'm going to do it right, because by God, if I'm not going to do it at all, I'm going to do it at all, and I'm going to do it right. And none of that made any sense because it's midnight, and I'm going to keep it because I don't edit, because I've got no shame in this ridiculous, ridiculous game. And you guys are my claim to fame. And what's my name? It's M. All right. So, drug class. It is an anti-tubercular. Okay? So it is a bactericidal for the treatment of intracellular and extracellular tuberculosis. All right. So it also takes care of something called Neisseria meningitis. When you see this, it is going to look very bizarre because it's not spelled like Neisseria. Just know that I remembered it when I heard it. I remembered one of my favorite languages and voices I love to hear. One of the most beautiful accents is, to me, a Nigerian accent is one of the most beautiful, most glorious accents. So I thought, Nigerian, done. Perfect, done. Pack it up, stick it in your heads up display, the little Iron Man, pop it out, swish it around, throw that little piece out, put it together, make a mechanism, right? The little Iron Man McGee. You have that ability in your brain. I'm trying to help you unlock it. It's beautiful. When you open that bad boy, there ain't no holding nothing back. You could rule the school, I promise you. But you got to get it open. And when you do, yikes! I'm looking forward to it, friends. All right, backing up the train, going back to boring old tuberculosis. All right, so this is given oral, this is given IV in some cases. It's metabolized in the liver. It's excreted by the kidneys. It's metabolized by the liver. Hang on to that for a second. If I tell you it's metabolized by the liver, what's going to be the no-no for that? Think about that. I'll be right back. All right. So what does it do? It kills the mycobacteria. How it inhibits the synthesis of the RNA, basically. It causes it to tell it that it's defective. It's non-functional, right? Those are non-functional proteins, basically. It sends a signal that says, no good, all right? It eliminates the TB bacilli from the sputum in combination with the INH, right? So, how do we use it? Well, we treat susceptible TB infections. I talked to you about the meningococcal meningitis. I talked to you about Neisseria. I talked to you, leprosy, it takes care of leprosy. That's still a thing, guys. Hey, guess what? When you guys get frustrated that you did not get a 78, that you only got a, I don't know, 68, all right? Remember that leprosy still exists, friends, okay? Let that be the moment that helps you remember who you are and why you should continue to be strong, to take a deep breath and to know that it's okay to not be okay. I'm going to say it one more time. It's okay to not be okay. One more. Go for Nikola Tesla. He loved 3. It's okay to not be okay. That, my friends, is humanity. And do you know why I know that? Because there is a little piece of human in me, friends. I know you think I'm a cyborg, but I'm there. And that little conscious piece of me that is human has been begging and dying and pleading to get into your world. And I'm so glad I finally got an invitation. Because now I done put my foot in. Y'all are in trouble because I ain't letting go. And I tell you what, I've been fighting hard. If I ain't stopped now, I ain't gonna. So I'm here. Let's have some fun. All right. Backing up the train. Sorry, I had to get on my soapbox to just tell you it's okay, guys. You're going to do good. You're smart. I'm so proud of you. I'm so proud. Okay. Let's see. I talked about all the things that it kills. All right. Contraindications. This is the stuff you guys need to listen to. Hypersensitivities. History of alcoholism. Okay. Why? Because it comes from your liver. That's why. All right. Receiving treatment for HIV. This medication is hard on your body. You have to take it for a long time. Sometimes 6 months. Usually 6 months. I'm going to stay on the medication. I'm not going to stay on the disease process because TB has a lot of questions related to it. Really quick, just in case you want to go there, if you're listening, you're also working on exit stuff. Here are the top TB questions. You ready? Tuberculosis patient, what type of pressure do we put them in? Negative. All right, cool. Do we have visitors? Nope. Although that's negotiable nowadays. I don't want to get into that in the hospital system. It's every hospital that I've ever been in the last 5 years, and that equals to about 10 to 12 hospitals. Anyways, moving on. So, yeah, there's that. Negative pressure. Oh, what type of diagnostic exam is the confirmation? Guys, it's not the chest x-ray. Also, what is induration for a positive TB test? Also, what is induration for a positive TB test if they are immunocompromised, HIV, AIDS, cancer, right? What's the difference in induration? All right, cool. Is that a test? No, that is that is not a confirmation of a test. You need an acid-fast bacillus test. You need to have 3 sputum cultures. You need to have them looking as so. What else? You need to tell them about no alcohol. You need to tell them about chest x-ray to confirm, but not quite confirm, just kind of confirm. Because the acid-fast bacillus is the actual confirmation. Let me make that perfectly clear because that's absolutely a thing. I think I just covered TB. All right, let's go to the next slide. And sorry if I broke your brain with all that craziness, but I feel like it needed to happen. All right. All right, friends. So I don't do very well with every single name perfectly, but I'm going to give this one a go. I think it's acetylcysteine. Nope, because that's not an L. It's acetylcysteine. I still want to throw an I in there when there's not one. I'm telling you. Acetylcysteine. Acetylcysteine. It's mucomyst, guys. It's mucomyst. Just don't make a thing of it, right? It's mucomyst. All right, so that's the generic, and then that's how we understand it. What is it? It's a mucolytic, all right? So what is a mucolytic? It breaks down the chemical structure of mucus molecules, right? So we use this because mucus becomes thinner, and then it can be removed easily just by coughing. Why is this important? Well, when we have people who are elderly who can barely cough as it is, this is our best friend because it makes it easier. It's used for patients with cystic fibrosis. Why is that a big deal? Because that's their thing. Look up cystic fibrosis patients. What do you need to know? Polycarpine ionphoresis test is the test for it, or the sweat test if you want to be, I don't know, basic, but my babies aren't basic, so it's pilocarpine ionphoresis, FYI. Yeah, cystic fibrosis patients, they basically have a really, really hard time because it's like putting molasses into their lungs. And I don't really know how else to say it because I'm not really talking about it, but there you go. That's what that means. Look it up, learn about it. It's a big deal. It's a thing. And when you have those patients, they're usually very young and they usually don't live for very long, although they are living much, much longer. But back in the day when I was a kid, back in this day of feral children, the 80s. What a beautiful time. What a glorious time. It was really tragic, if I'm honest. And by the way, we're the reason that you have a lot of your problems too. So, you're welcome. There you go. This is the circle of life. All right, cool. So backing up to a mucomist that takes care of cystic fibrosis patients. It also takes care of chronic bronchitis. Other diseases that produce large amounts of secretions, basically, right? I can think of 1,000 types of patients like this. But it doesn't need to be talked about. What needs to be talked about is just sticky ickies. That's all you need to know. Sticky ickies in the lungs. That's good enough. What does it do? Well, we get nauseous. We get vomiting. We get flushing. We get erythema. Ooh, what's that word? Look it up. I'm not going to tell you everything, guys. Erythema. 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 That's a word you need to know. If you don't know that word, look up the word. Feeling sticky on the face. Having like an unpleasant odor, okay? So why would all these things happen? Why would I get this way? Well, it's pretty simple. Your job is to cough. And when you cough and then you cough some more, you choke on your cough. And also sticky ickies are coming out. So then you choke and then you gag. And then when you gag, guess what? Sometimes you just ate and things come out. And then you get flushing because you feel like you're about to do it again. And then you get stickiness on the face because you're sweating and you're probably really embarrassed too. And you're getting sick. And there's an unpleasant odor because guess what? That just came from your belly and your lungs. So, yum. If that made you sick, I'm sorry. This is nursing, friends. It's going to get grody, especially if you work on a pulmonary unit. And guess what? Pulmonary units are always available for brand new nurses. Go find your local one. You're really going to learn a lot, and it's really not that bad. I love pulmonary. There. A neurology buff over here loves pulmonary. I said it. I also love trauma. Those are my homeboys. I love those guys. Those are special. Also, about 15 other people. But anyways, digressing. What am I missing on this? This is why we're feeling this way. This is how I need for your brain to download the information I'm giving you. Again, adverse effects. When do I now need to tell this person stop? When they have severe vomiting. That's a big problem. When do we not use this medication? We don't use this medication in patients with bronchial asthma and with patients with severe respiratory insufficiency. Why? Guys, if I have severe respiratory insufficiency and I am making you cough, how stupid is that? I don't mean to be funny. I don't mean to be ugly and say the word stupid. But guys, that's just stupid. Ignorant? No, it's not ignorant. No. It's not ignorant. And here's why. Because I just told you. So now your age of accountability is host. Sorry. Love ya. Kisses. Okay? All right. So make sure that you understand those simple things. We need to make sure that we assess respirations because this person's going to be coughing stupid. Some people, it doesn't really bother them that much. They're able to just do one cough and it all comes out. Some people get really, really bad off. And then we have to worry about, is this going to get so inflamed that I'm going to worry about stridor? So this is something we have to watch out for. It rarely happens, but it does. In some weak people, it does. Get baseline labs. Make sure that you got, things in place so you can, push fluids on this patient if they're able and help loosen those secretions up, right? Increase fluids, cough and deep breathe. things of that nature. Making sure that they're not eating a freaking stack of crackers and peanut butter. That's super smart. Don't get them milk and peanut butter and crackers while you give them Mucinex. Like, I say these things and I'm laughing, but I'm doing it because I'm totally beefing out in circa 2019. I can tell you what hospital I'm in. I can tell you a room. It was room 602. Oh my God, crazy. And literally, I've got this poor little patient who's trying to eat. They had had pneumonia. It was a wonderful, wonderful family. The gentleman was very elderly. He was 92. And he was a professor. And he was still a professor and so upset about this pneumonia. And I just wanted to fix this guy. And this poor brand new nurse who thought she did such a great job, and she did, it was so wonderful, gave this poor person who was just recovering from pneumonia, who was eating Mucinex like candy, like Tic Tac's friends, milk and peanut butter and crackers. For the love of Pete, has anyone done that? If you haven't, do it and whistle. Just whistle. Okay, that's how much breath it takes to breathe. Okay, cool. How many whistles do you get? That's what the lungs feel like. All right, I'm done with this medication. Let's go to the next. Okay, so we're going to go over loperamide. And I tell you what, loperamide, it stinks. It does. It stinks talking about it. Why? Because it's called Imodium. And what's the purpose of Imodium? Well, it's an antidiarrheal. Did you get the joke? There. Silent laugh. Pregnant pause. There you go. Pharmacologic classification. So its purpose is antidiarrheal. It's usually an oral medication. What it does is it inhibits peristalsis. What is peristalsis? Let me back up the train. Peristalsis is when your intestines move and groove all the way down the pipeline. Literally a pipeline. And it moves things down and it wiggles and jiggles. And why does it do that? Because it moves the poo down, and that's how it does it. Okay? It's got little fingers. It's called microvilli, which are the teeny tiny fingers. Those suck and absorb. And then it's got villi, which are the bigger ones, right? And those move things along. I think I might have said that backwards. I did not say that backwards. I said that correctly. One moves things along. One kind of knocks things down. And as it knocks things down, it absorbs. All right, cool. Those are those two guys. One's big, one's small. Villi, big. Microvilli, small. All right, cool. The word micro is in there. It's Latin for small. Okay, cool. So, moving back. It inhibits peristalsis and it prolongs the transit time, okay, on the nerves in the intestinal muscle wall. So what does that mean? It means it slows peristalsis. It tells that intestinal wall to chill it out, right? I want you to think of a drill running very fast versus looking at a barber shop, the traditional barber shop, how it had that little spinny thing in the front of it. That's the difference, friends, okay? So it stops that. Now, what else do I care about? Because there are a couple of things with Imodium. Now, keep in mind with this medication, if you have a history of constipation, you don't want to give this medication. Duh. Because it's Imodium, it's going to make it even worse. You're going to get backed up and blocked up, and then you're going to be vomiting poop. Yes, that's the thing. It wasn't just an episode on South Park, right? It literally happens. I've seen it. People die that way. It's funny haha to watch it, and then it's not so funny haha to see it, right? Sometimes you can't get a tube down fast enough. It's unfortunate. But here we are. All right. So, sorry, give me just a second. My brain is trying to build something, and also I'm trying to figure out test bank questions that I've seen in the past. Oh, Imodium. When you're dealing with a patient, a C. diff patient is a good patient to give Imodium to. However, you must get a C. diff sample prior to dosing Imodium. Why? Thank you for asking why. Because if I have any bit of solid bit in there, they are going to give me that back and throw it at me. It is supposed to be liquid. If it is solid, it is not C. diff. Now, is that true? We're finding out that's not exactly accurate. Also, while I'm on the nerve of talking about C. diff, people say you can smell C. diff. There are scientific studies where we have physically tested somebody's ability as a veteran nurse to be able to quote unquote smell C. diff. It is a myth. I promise you. Just as I am inaccurately singing keys in the wrong chord. It's not a thing. I'll fight you with it. I will show you the article. It's recent. It was done by a top 10 university in the nation, top 3 even. Okay, fine, it was top 1. There, it was done. It's not a thing. Okay. Moving back. You have to have a solid specimen first before you can dose a C. diff. That's going to be a question. That's always a question. I don't know if it's on this test. It's always a question, period. All right. What are the side effects? Well, constipation, cramping, abdominal discomfort. Why? Well, because I'm slowing everything down. If you're eating a lot and you're slowing it down, that's not a good thing. It's going to hurt. Potentially nausea or vomiting if it backs up, right? You need to assess the bowel function. You need to look at electrolyte and fluid labs. If this person is getting better, you don't want to give this person Imodium and then start blocking things up and then reversing it in the worst way possible, okay? So there's a balance to this medication. You have to check skin turgor of the patient. If they look like they are dehydrated, now is a good time for Imodium and fluids, okay? That's a good idea. What do we need to teach them? Well, there's a lot of things we need to teach them. They need to watch their stools for diarrhea. If it gets better, which it should, then everything's okay. Once they start to feel better, it is encouraged that as they start to feel better, they start to level off of this medication so that you don't have to start keeping on it, right? Because we have to taper it down at a point. Report any fever. Report any abdominal complaints. This could be a problem with you having too much of this. And you could also get severe leukopenia, which is a big side effect of this medication. All right, why? Without getting into ridiculous amounts of pathophysiology, just know that it gives you severe leukopenia. So what do we need to watch out for? Okay? Dry mouth. What do we need to do to help it? Keep them hydrated. Thrombocytopenia. What does that mean? Thrombo, clot, cyto, cell, penia, small. Remember your Latin. Okay? What that means is little itty bitty tiny purpura spots, right? Kind of coming up everywhere. So you look like severe bruising, but it's a weird kind of bruise. It's not a black bruise. It's not a blue bruise. It's a purple bruise. And it kind of is oozy looking. It's weird. Look it up. Thrombocytopenia. You won't forget it when you see it. Urinary retention, dizziness. Okay? Make sure you get those. And that's basically it for Imodium. So let's go to the next one. All right. You ready for this one? Polycarbophil. Polycarbophil. Okay? It treats occasional constipation. So what it does is it works by increasing the bulk of your stool. It increases the pressure, and that prompts the muscles in your intestines to basically move the stool, basically. There you go. It also softens the stool, and it makes it easier to have the bowel movement if it's softer. It is a medication known as laxatives, and it's used for a couple of other purposes. It's commonly known as like a fiber laxative, FiberCon, fiber tabs, things of that nature. Now, if you have certain conditions, it's a no-go. If you have blocked intestines or a bowel, it's a no-go. If you have change in bowel habits for more than 14 days, it's a no-go. You got a problem. If you have high levels of calcium in your blood, it's a no-go. Okay? If you have kidney disease, for the reason that I just mentioned, and because calcium, look how calcium affects your kidneys. There's something in there that you need to be aware of that you're not paying attention to because you're too worried about sodium, but you need to worry about that as well and how that affects the system. Stomach pain, nausea, vomiting. Why? Because my belly hurts because you got it jiggling and squiggling everywhere. That's why. Trouble swallowing sometimes because that stuff is like thick. There's a reason it's called bulk, right? Bulk, just like I like my people. Bulk. Yo, that's good. That's some good stuff right there. But the problem is sometimes it's too much. So you got to basically stir it, drink it, done, right? Or you're in trouble. There is a caveat, I think, about breastfeeding. But we're going into Babyland territory, and unless I'm having one, I'm not paying attention. That sounds awful. I'm sorry. I'm just not cool enough for Babyland. There's only so many people, and I'm not one. But I think that's all we got for this. What interacts with this medication? Dig interacts with this medication. Phenytoin interacts with this medication. Some antibiotics. Tetracycline. Ciprofloxacin. Levofloxacin. Doxycycline. Thyroid hormones it messes with. Okay. I'm just throwing little factoids out that may or may not be on exams that I've seen in the last, 12,000 questions. Sorry, look, I'm Iron Manning it up right now. I'm trying to figure it out. All right. I think we're good. All right. So allergic reactions, skin reactions, itching, hives, swelling. This is a thing. This is just a thing. If you have trouble swallowing, that's not good. If you have side effects, it's going to be things like bloating, nausea, stomach pain, gas, diarrhea, right? Because that's what it's supposed to do. So just back off of the medication. You're fine. We need to tell people things like this because I swear they really don't understand. So please understand the difference between the antidiarrheal versus the bulk forming laxative and its name and its common name and what it can cause if there's too much and what we need to be aware of to tell them to back off of that medication once they have had too much. All right. So I think if you got all those things, you're good for this medicine. We will go to potassium iodine solution, I believe. All right. All right. So this is actually, hang on, let me fix this. This says potassium iodine. And I'm like, wait, that didn't feel right when I said that earlier. And it's because it isn't right. And it's cool. It's cool because you know what? The reason you have this lecture is because of a beautiful student of mine who did a fantastic job, who wanted to study a little bit better, and said, hey, can you do me a favor? I'm going to give this to you. Would you talk over it? And I was like, heck yeah, I'll talk over it. And now I just kind of do this as your way of studying, but I do it for every class if you guys and if you bug me about it, because it's a smart idea. It's a very smart idea. Keep doing this, guys. All right, so potassium iodide, not iodine, iodide. Potassium iodide is used to treat overactive thyroid and to protect thyroid gland from effects of radiation. So this is also used for radioactive emergency. Or from inhaled or swallowed radioactive iodine. It can also be used before and after administration of medicine containing radioactive iodine or after accidental exposure. So if I'm at a nuclear power plant, which is a terrible example, by the way, but really the only one where you would ever be exposed to such a molecule, if I'm honest. So here we go. I'm doing this. You need to be released from that environment and from that radioactivity, and that's how we would do that as well, right? So that was one of the many ways we tried to get people back during some very horrible times in the 80s, if you want to go into it. These were some of the people who were out of earshot enough to not die from that incident, and that's what we did, is we doused them with this stuff to try to help, get some of that radiation off of them. It's quite tragic. If you don't know what I'm talking about, you don't need to worry about it. If you do, look into it. All right. So, it's taken by mouth. It can be taken as an oral syrup. I've seen uncoated tablets. I've seen air-coated tablets. It doesn't matter. They have delayed release tablets too. The delayed release has the most serious side effects because, of course, the release is delayed, right? So, of course, you're going to have the longest level of exposure, right? So, more opportunity for screw-ups, right? Basically. Like I said, nursing is common sense, and I teach common sense nursing for common sense students for a reason, because you are the common sense student, so you get what I'm saying, because it's all relatable to everything we do all day, every day. We just don't see it, because we make a big deal of it, because we say people in medicine are somehow better than anybody else, and they're not. They're not. Jeez, not even close, probably worse. Ugh. Anyways, so what else do we need to know about related to this medication? I mean, breastfeeding, I don't remember anything that says one way or the other. Medications that interact with this medication. Coumadin, this is a big problem. Beyond that, I can't really think of any, but I'm sure there's others. Problems. If you have problems with high blood potassium levels, you got to watch out for this medication. Tuberculosis. Tuberculosis. If you have tuberculosis and you take potassium iodide, it will make things worse. That's a no-no. Kidneys. Kidneys. Where is it? What is it? Hang on. I'm filing. I'm screening. Potassium. Potassium. Kidneys. If you have kidney disease, it's going to increase the potassium in your blood if you take this medication. If your thyroid is overactive, unless you're taking the medication for that problem, prolonged use can be harmful to that thyroid gland. So if you have an overactive thyroid, or unless you're taking the medication for that problem specifically, prolonged use is going to deteriorate it, right? Because that's kind of the point, right? So watch out. It's going to upset your stomach. Take it with meals. Take it with food or milk, unless your doctor says no. Stomach upset's a problem. That's obvious. I'm trying to think of anything else. You can get joint pain. You can get hives, although that's very uncommon. Long-term use confusion, headaches, soreness of the teeth and gums. I really got nothing else. That's basically this. All right, next slide. So again, this was created by a beautiful student of mine who is a beautiful sister. And I think that she is just the bee's knees. She's going to do very, very well. She busts her back end so hard all the time. She's constantly calling me, communicating with me. I could not be more proud of her. And she's going to leave the last slide as the most intense, most ridiculous, most amount of information. And she's going to put it at the very end. And I am just ready to go to bed. My beautiful, beautiful woman. You know who you are. Thank you for this last slide, because guess what? Remember, what you put into this earth, you get back, so you have to listen to all of this. Okay, corticosteroids, friends. Corticosteroids, also known as just steroids. They're anti-inflammatory medications, all right? They are prescribed for a wide variety of conditions. They're a synthetic version of hormones, normally produced by your adrenal glands. Those are the two small triangles on the top of your kidneys, okay? The pyramids of Egypt flow through the Nile. Literally. Isn't that hilarious that I just said that? And that's exactly what it is, because the ureter literally looks like the Nile. And, okay, anyway, sorry. I'm digressing. Anyways, back to corticosteroids, all right? Corticosteroids, they're mainly used to reduce inflammation and suppress the immune system, okay? Let me say that one more time. Corticosteroids are mainly used to reduce inflammation and to suppress the immune system. I just said suppress the immune system, so I think we can already see how this could be a complication, A, over time, B, if you have any immune deficiency issues, C, hello, what does that mean for people with like blood sugar issues, okay? Think about these things, guys, as I talk. All right, cool, because all these are coming back again, I can promise you. They're used to treat things like asthma, allergic rhinitis, lupus, Crohn's disease, multiple sclerosis, atopic eczema, hives, colitis, COPD, Addison's. I got nothing. If there's anything else, man, you're cooler than I am. All right, I'm done. So how can we take it? We got injections, we got inhalers, we got lotions, we got tablets, we got all kinds of steroids around here. Okay? These are not anabolic steroids. That's a little different. Guys, we're not giving Arnold Schwarzenegger roofies around here. These are corticosteroids, okay? So, steroid inhalers and steroid injections shouldn't cause any bad side effects generally, okay? Because of what their purpose is. All right? If you have problems with steroids, they should be used in caution with certain people. So, if you have mental health or behavioral problems, why? What do they do? What do they trigger? How do they make you feel? If they trigger the adrenal system, you know, the thing that when you get shot, you look down and you go, oh crap, there's blood. And then it just keeps pouring, and then you're somehow still moving, and you don't really realize that you've been shot and it burns. Yeah, that stuff. So I just heard my best friend laughing because in the offshoot that they hear this, because they are currently, achieving greatness themselves, they're going to laugh because they get my sense of humor. Anyways, sorry, digressing. This is why we have mental health problems related to the adrenal glands. All right, liver problems, liver disease. That's a big problem. Why? Well, see what steroids do to the liver. See the mechanism of action. All right. Delayed healing of wounds. Think about why that matters. I'm not going to give you every answer, guys. You guys are smart. I'm challenging you. Okay. Why is delayed wound healing a big deal related to corticosteroids? Okay. Because, well, there's prolongation of an adrenal system. And if you're in sympathetic nervous system, you're not in parasympathetic nervous system, which means you're not resting and digesting and healing and wheeling and dealing. Duh. Right? And there's a couple of other reasons, but I'm not going to get into it right this second because we're not talking about that. We're not talking about pathophysiology. We're talking about pharm. So let's go back to pharm. Duh. Sorry I even got you there. All right. Also, corticosteroids. Your sugar sucks. Why? It suppresses the system, which means it suppresses that ability as well. So if I give you corticosteroids, you are more than certain to have the worst blood sugar. So I got to worry about throwing you into DKA. All right. So you got to worry about that as well. Let's see what we got here. We have heart failures, heart attacks, high blood pressure, epilepsy, diabetes, glaucoma. Why are all these a problem? Again, I'm stimulating the trigger of all of these things. Obesity, it's going to make you bigger. Osteoporosis, I'm going to eat your bones. Adrenal glands love to eat bones. It's their favorite thing in the world to eat. It's a sweet little treat. It loves the marrow. It's yummy, yummy in their tummy. Okay? I don't know how else to say it. Psychosis. Do I want to give a steroid to a person with a psychotic disorder who's in exacerbation? No. That's a terrible idea. Stomach ulcers. Again, I'm dumping gasoline, aircraft fuel, if you will, onto a fire. Yikes. And throwing a little bit of ether on it. Don't need to throw it, just need to remove the cap. And guess what? The flame will follow the ether back to the barrel. I promise you, I know for a fact. Don't ask how. All right. So, steroids. They're safe during pregnancy generally. I can say that because I have a very smart friend who is Babyland, and I trust her when she says things out loud, and I memorize everything she says, and she doesn't realize that. So, I know that. And beyond that, there's a lot, but it's not related to pharmacology. It's related to pathophysiology and or disease processes, which have nothing to do with your pharmacology questions. So I'm not going to go there. That's more Med-Surg 1, Med-Surg 2, exit HESI, da-da-da-da-da. I'm not going to go there. So, in conclusion, this is meant for my one student. However, I know that other students are probably going to watch this. So me and my banter for 84 minutes has been for her because she has needed this to feel confident. This person has been working on confidence, just like all of you guys are working on confidence. Guys, guess what? Just like I'm working on confidence. Yo, I'm a bad mama jamma. I know that. But guess what? I'm still the little kid who was on the short bus, who got made fun of, who was picked on for being different. Hey, guess what? I'm not alone anymore. You guys are here with me, and you're getting it. And you're starting to realize that maybe you and I aren't so different after all. In a lot of ways, both good and bad. Which means we have the ability to transmute ourselves from what we were and all the things we didn't want to be. We can manifest and be somebody that can prove to be truly limitless in this existence. And any other, if that's what you believe in. Cool. So, to my dear sister, I love you and I'm so proud. You are going to kill this exam tomorrow because you are truly special, friend. You are truly special. And I hope that you do well, and I know you will. And I can't wait for your text tomorrow to tell me how great it went. All right? Signing off, out. Love ya, and bye-bye.